My name's Paul. As you said, I'm one of the IMT trainees up in Glasgow at the moment. And today I'm just going to try and get us all feeling a bit more comfortable with ECGs. It's almost Christmas. I'm sure this is exactly where we all want to be. I've got my Christmas tree here. I've got Christmas tea. And I've also got a lovely Christmas mug, actually. I don't know if you can see it, but there are penguins involved. So it's all wonderful. So I'm going to use today just try to make you leave feeling like you can actually interpret ECGs, and that can sometimes be something that trainees struggle with. So by the end of today, I want you to be able to have a simple way to interpret ECGs, and not so much for real life, but for OSCEs, it's particularly important to be able to interpret them quite quickly and be able to interpret them in a logical way that'll just let you get marks. Not so important in real life, but for OSCEs, which is a bit of a driving test situation, it's really important. And then we're going to do a wee bit on kind of common and dangerous ECGs. I'm not going to spend too long on that for reasons I'll explain, but just a little bit, just so we can have a bit of a chat about what ECGs you're worried about, what ECGs you think you might get presented with at an OSCE. Just a wee reference, all ECG examples that I've got in here can be found online on the phenomenal website Life in the Fast Lane, which I'm sure you've all had experience using, but if not, I would check that out immediately. So let's go. So first of all, I just want you to say, how do you feel about ECGs? When somebody's on a ward round and says, what is on that ECG? What comes into your head? Do you feel happy? Do you feel panicked? How do you feel? Is meant to working? Yes, it is. Okay, good. Scared, love them. It's pretty decent. Okay, brilliant. Scary scribbles. Okay, so somebody's a master. Oh my god, do you want to do the talk? Because I don't think I'm a master. Quite good, cool. Fine, hate them, tensed. Okay, so it's a bit of a wide range. So there are obviously some people that you get tachycardia. Alas, I know, mate, so do I. Concerned, fine. So I'd say maybe some of you feel okay, some of you feel really confident, which is great, and then some of you feel how I did as a student, and I felt horrendous, and I did not enjoy the experience at all, and I always made a great fool of myself and usually went for STEMI, and it was almost never a STEMI because it was usually an award and they were fine. So this is a common way that trainees feel, and that's okay, and I'm going to try and make you feel at least a little bit better about it today. But that's good to know. So, in your head, what are the big things you don't want to miss on an ECG? I don't think that's a Menti. So, if you just want to comment in the chat, what sort of diagnosis do you not want to miss? Do you think? STEMI, yep, absolutely. Anything else? STEMI? MI, yeah. I thought this might be the answer. Absolutely, yeah. Anything else? Also, guys, heart block, VF, AF. Okay, cool. AF, yep, fine. So people kind of saying kind of similar things to what I thought as well, but we'll kind of revisit this at the end. So what I want you to do is have a piece of paper next to you, maybe you already do, or if you don't have a piece of paper, the notes app on your phone, or just something you can kind of jot stuff down as we go through, because we're going to kind of be working through a process together. And the most important thing about ECGs is to have a process, because if you have a process, particularly in OSCE, you're going to get marks, okay? And that's what I want you to remember. So the things that I think you don't want to miss necessarily are, as you said, MIs, atrial fibrillation, and a cardiac arrest rhythm, which you'll probably experience more of as you go through your training, but VF, VTs, torsads, complete heart block, essentially, what I'm trying to say in fewer words is things that might mean people are about to die, which generally as a doctor is what we kind of want to try and avoid. So if you can identify these things, the kind of small print things like bifascicular blocks, the right bundle branch blocks, all the kind of mental things that cardiologists talk about, actually, as an FY1 on a ward, are you going to really be focused on that? I would suggest probably not. And that's why in an OSCE, these are the things that are most likely to come up and the things that you don't want to miss. In real life as well. But what I want you to remember throughout every talk today, every OSCE revision session, and in the OSCE itself, the process is always going to be more important in an OSCE than the diagnosis. So if you have 10 points to get in an OSCE, 9 of them are going to be about the process that you take. 1 mark is going to be oh good, they got the diagnosis. So if you get an ECG and you think, I have no bloody clue what this is, that's okay. You go through the same process that we're going to talk about today, and if you do that, you'll get most of the marks and you'll pass anyway, even if you're grossly wrong with your diagnosis. And that's the most important thing about OSCEs. And also it's a bit of the weird thing about OSCEs as well, because you can get very hooked on making sure I don't miss the diagnosis, but actually, if you get the process right, you'll be fine. So without further ado, let's talk about the process. Those of you who feel confident with this probably already go through this process. You will have been taught this kind of process before, but again, it can get very complicated. So I'm going to try and keep it as simple as possible. So rate, rhythm are the first two. Axis. Now, I'm not particularly bothered about axis. You can mention it if you feel confident. I wouldn't get too hung up on it, but we'll talk about that a bit more in a minute. And the waves, which are probably the majority of what you're going to be doing. And then you want to summarise what you found, which is that last wee point at the end, which may just get you from 9 out of 10 to 10 out of 10 or whatever. Okay, so rate. The rate is pretty straightforward. In real life, it tells you at the top. Hallelujah. But in OSCEs, unfortunately, they'll probably scrub that part off. So the way I do it is I look at the number of small boxes between the tip of the two R waves, and I divide 300 by that number, which is the way I was always taught to do it, and I just find it that's the way I defaultly do it. What a lot of people do, and this is totally acceptable as well, is look at the rhythm strip across the bottom, and that'll be 10 seconds of ECG. So you count how many complexes there are in that and times it by 6, and then that gives you a kind of approximate thing. Important thing to remember is if the rhythm is irregular, some of these won't be particularly accurate, all right? But whatever way, just find a way that works for you. I don't really care. The OSCE examiner doesn't really care. The patient certainly doesn't care. Whatever works for you, do it, as long as it gives you a good answer. And then after that, you'll have done your recalculation. You'll say the rate is whatever it is. So 90 beats per minute, which is normal, 150, which is tachycardic, 20, which is bradycardic. And that'll be at least one mark. Tick, done. Easy, right? Easy. ECGs, easy. Rhythm. So remember, there are only two options. So even if you guess, you have a 50-50% chance. But there will only be the two options, regular or irregular. The vast majority of ECGs are regular. And then irregular, if it comes up in an OSCE, you're probably going to be thinking along the AF route. So you'll probably been taught this in placement 4, but get a wee bit of paper, put it under the first 4 QRS complexes, put a wee line underneath where the QRS complexes are. There we are, we have that. And then move that bit of paper along the rhythm strip. And a QRS complex should be found above every line every time you move that paper. If even it's a wee bit out, you could say it's irregular. All right. And remember, in an OSCE, irregular probably means AF. There are a whole host of irregular rhythms that cardiologists get all happy about. 95% of the time, an irregular rhythm is AF. Okay. So if you see an irregular rhythm, say it's an irregular rhythm, and then move on. Don't say the diagnosis yet unless you're absolutely sure. And otherwise say the rhythm is regular. That's another mark. Tick. Phenomenal. And already we might be starting to think, okay, maybe we do know the diagnosis, and that's fine. Cool. So that's the rhythm. Now here we come into my least favorite part of the whole ECG, the axis. It's it's small print. Axis in an acute setting usually doesn't change a bloody thing about what you do. It's small print stuff. Normal axis means the first 2 leads, everything goes up. In a left axis deviation, the lead 1 goes up, lead 2 goes down. It makes a wee diamond, and that is like diamond rings which you put on the left hand usually. That's how I remember it. And then right deviation is the opposite, so they point towards each other. 1's negative, 2 is positive. Okay, that's all I'm going to really say about axis, because as I say, about 40% of young people have a right axis deviation anyway, and it doesn't mean a bloody thing. Left axis deviations can be a bit more dangerous, but again, we're trying to think about high yield stuff in an OSCE. You're not going to get hung up on axis, okay? So if you're getting hung up on axis, move on. If you know it, say the axis is normal, there's a left axis deviation or a right axis deviation, right, that's it, okay? Axis is not the most important thing here, or in real life, okay? If for example, if anyone called me when I was on call and said, oh, I've done this ECG and there's a right axis deviation, that's about it, I'd be like, oh, okay. All right, so axis, moving on. This is the majority of it. This is the bit that tends to get people in a bit of a tiz, the waves. But if you go through this process here, you're going to get most of the marks that are associated with an ECG, right? Here we go. P wave. All you need to know about the P wave, is it there? If it is, great. Is it always there? If it is, great, that's normal. So say P waves are present and there's one before every QRS complex. Mark. Tick. If it isn't there, you're starting to think about AF. The PR interval, again, more small print. Don't get too hung up on the PR interval, but is it less than 0.2 or 200 milliseconds? Five small boxes. Is it less than that? If it is, great, it's normal, move on. Okay, this is all about quick interpretation to get you your marks in your ECG station, okay? So P, PR. Now we're on to the big bit, the QRS. There's only one thing to know about the QRS. Is it narrow or is it broad? Narrow is normal, broad is not. Okay, and technically narrow is less than or equal to 3 small boxes. All right, at the broad part, okay? So is that less than 3 small boxes? If it is, great, move on. Is it always there after a P wave? You've kind of already done this in the P wave thing, but good to check again. When there's a P wave, is there a QRS? They're pals, they love each other, they go everywhere together. If they're not, there's an issue. A big issue is called complete heart block. Okay, don't worry about it too much. Just say the QRS is narrow and there's a QRS following every P wave. Beautiful. If I was that examiner, I'd be like, yeah, tick. Then we get on to the one, the famous, the star of our show, the ST segment, everyone loves so much. You can get so hung up on the ST segment. All you have to do is look at the QRS, right? The line after the QRS should be on the same level as the line before the QRS. Okay, that's all. If it isn't, it's either too high, in which case it's ST elevation, or it's too low, which is ST depression. Comment on it, move on. Okay? That's all you have to do with the ST segment. T wave. Is it there? Great. Is it pointing up in most of the leads? Great. And that's ECGs, all right? If you do that for every ECG, you're going to get the majority of marks. Remember, this is all about getting a quick, snappy process that you can do under pressure that's going to get you marks, all right? That's not going to get you all confuddled and confused with fascicular blocks and SVTs with aberrant conduction and all this nonsense that actually are really rare and OSCE examiners are not particularly interested in. Okay, moving on. So, as I say, that's kind of it, to be honest. So, any questions right now? All right, because I realise that there is a whistle-stop tour because we don't have too long. Any questions? If not, don't. But if there are, that's great.
We've not got anything in the Q&A chat or on the main chat at the moment.
Somebody's written, so clear. Good, that is what we need here. Wonderful. We're all going to be ECG experts by the end of today.
Sorry.
I will repeat common scenarios. We're going to do that in the next few slides. Okay. So this is why you need your pen, your paper, and a notes app. Okay. We're going to do it. Are you ready? Are you ready, folks? Let's do it. Wonderful. We're all so excited about ECGs. It's so great and so unusual. Right. Here is an ECG that you may be presented with in an OSCE. I'm going to give you 30 seconds, 40 seconds, 45 seconds. Get your pen and paper, get your notes app, go through the process like we did before. Okay, I'll put up the process there quickly. So I want you to go through that with this ECG. All right, take 30 seconds and I'll sip my tea. It's wonderful. We should have like relaxing Christmas music for this part, shouldn't it be lovely? And again, if you're confused why, I'm going to go through everything in a minute, so don't be too worried about anything. Okay. Okay. Everybody ready? If you need me to go back in a minute, just let me know. Okay. We'll jump back and forward to the ECG. So, even if the abnormality is obvious, which it will be to some of you, it won't be to some of you, and that's okay as well. You go through the process. Ignore the abnormality for now. The process, okay? So here we go. We've done rate. What is the rate? Oh, AF strictly 100. Delightful. The rhythm, okay? You're having the rhythm in your head. Let's go back to it. So now obviously we can't, the joys of Zoom, we can't really do the paper thing, But I would tell you that I think if you look at, particularly in the rhythm strip, which is a great bit to do your rhythm, you'll see that this, just to the naked eye, looks a lot further away from that than that does to this. Right, okay? This looks a lot further away to that than that does to this. Okay, so this one's a nice clear one, which is why I picked it. I think the rhythm is irregular. But move on. You'll be saying the rate is 100. The rhythm is irregular. Axis. Now, do we care about the axis? I mean, not particularly. I would say that that's probably normal, bordering on a mild left axis deviation, but they're both pointing kind of up. The axis is normal. Move on. We don't care. No damns given. Okay. So, P wave. Is it there? So the P wave, as I'm sure you all know, married to a QRS. They're lovers. They love each other. They should always be together. Is there a P wave? Again, rhythm strips, great for P waves. Okay, just think, is there a P wave? Wonderful. The PR, is it less than 0.2? You can't, to be honest, this is not the best projection because it's on screen. I think it's slightly hard to tell because there's something wrong with P waves. Moving on. QRS, is it less than 3 small boxes? Again, sorry, screen, slightly hard to tell, but is it less than 3 small boxes? ST segment. Is this line here level with that line there? Draw a wee line between them. Draw a wee line between them. Draw a wee line between them. Is it level? Is it not? T wave, is it mostly pointing up? Okay. Here we go. Now, again, if you get it wrong, I don't care. It's all about you. All right. So, have a guess. What is the issue with that ECG? You've gone through your process. What do you think the diagnosis is? STEMI. Okay. In-house. Yeah. 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 AF. AF's winning. These are lovely colours as well. It's all pink and cute. Nobody's saying SVT complete hardblock. Thankfully, nobody's saying there's no issue, which is great. Atrial fibrillation. I'll give you another few seconds to answer. Atrial fibrillation. Oh, another vote for STEMI. Another vote for STEMI. Another vote for atrial fibrillation. Okay. 15. There was somebody's answer in the Q&A. So I'm going to go through it myself, which is what I was thinking. Okay. Can I do that? Yes, I can. So if I was doing this ECG in an OSCE, I'd be like, hello, the rhythm. So I would do the rates, but it's quite hard because it's irregular. Okay, so you could set 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. So it's probably 13 times 6, which the reason I don't do this is because I always forget my mental maths, but it's probably between 70 and 80, but it's irregular. So the rhythm is irregular. We would go into our P waves. Personally, I can't see a bloody P wave anywhere. There's not one anywhere, okay? There are no P waves. Moving on, the diagnosis is becoming clear. It's irregular. There are no P waves. There are no P waves, so you can't tell if there's a PR interval. The QRS is narrow. There are no P waves, so you can't tell whether or not there's always one there. The ST segment is, for the large part, isoelectric, okay? So you may be looking at this here and this here, thinking, oh, there's a wee bit of ST elevation. That would be perfectly reasonable. And if you were an FY1 that phoned me with that, I would totally scare it. I'd be like, okay, fine. But actually, if we go to the point here where the ST segment starts and we draw a line very smoothly back, it's less than a box. Okay. If it's less than a box, does not count. Okay. So if it's an ST elevation, you will know because this point here will be tweaked up a few good boxes before above the line before the QRS. So remember, they should be equal and one box. I give no damns about. Okay, so I would say the ST segment is equal, and then T waves, are they always there? Yes, they're always there. Are the majority of them pointing up? Arguably, you could say yes. Arguably, you could say no. So there is some T wave inversion up here. There's a wee bit of a T wave inversion. That should be pointing up. That should be pointing up here. So there is some T wave inversion. Here, they're fine. There's a wee bit of T wave inversion. Okay. So, oh, John, don't worry, that's perfect. So, I would say that this shows an irregular ECG with no P waves, which I think is likely to represent atrial fibrillation. The rate is rate controlled, it's normal, it's not fast AF, it's normal. There's no sign of ST elevation. There is some T wave inversion, so there's a possibility that there's some ischemic change going on, but the main issue is it's AF. Okay, this is AF. Okay, does that make sense? But remember, even if you didn't get that right, if you went through this process, you'd have got 9 out of 10 marks. So remember, I don't care if you didn't get the AF bit. I don't care if you thought it was a STEMI. I care that you went through the process. Okay? So the AFs have it. The AFs have it. But the STEMI folk, I can see why you said it. And I say, I don't care that you got it wrong. You shouldn't care that you got it wrong if you went through a process. And if you had a reason for saying it, okay, fair. Okay? Next one. Take 30 seconds. Pen and paper, notes app, whatever you're using, go through your process. Okay? Go through it. You can do it. Just checking the time. Okay. I don't want to run over. So these slides, I'm assuming, will be made available to you, so you can always go through yourself. Okay. 10 seconds. Take a moment, go through the process. Okay. Okay. So let's go through it together. So the rate. So however you want to do it. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 times 6. Fine. Are there the rhythm? I would say the rhythm is regular. Okay. P waves. Are there P waves? Again, look at the rhythm strip. There's a little P wave there. There are so many P waves. It's so nice after the last one to see some P waves. And is there always a P wave? I would say probably. The PR segment, again, it's almost impossible to see here, to be honest. I'm going to hazard a guess that it's either on the long side of normal or maybe slightly prolonged, but actually it might be fine. Okay. But again, just say the PR, you would have it closer, so you'd actually be able to count the boxes. The QRS complex, is it broad or narrow? I would say it's narrow. Okay, it's less than 3 small boxes. Done. It's always there. Yes, there's always one. Hallelujah. There we go. Then we get onto our, the start of the show, the ST segment. What do you think about that? And then we get onto our T waves. Are they always there? Are they always pointing up? You've done the process. Now let's think about the diagnosis. Okay. What's the issue, folks? You've got this. I know you do. My goodness gracious me, I'm so happy. Yes, keep going. Let's see it go up. It's wonderful. Yes, mate. You're smashing the game. It's wonderful. Great. So I don't want to, again, we are really stretched for time, so I don't want to rush, but I also need to kind of have a wee look at this again, all right? If we look at this point here, which is where the ST segment is, and we draw our line backwards, it's more than 2 boxes higher than before. So this is a STEMI. Okay. Somebody said in the chat it's an inferior STEMI because 2, 3, and AVF are affected most. I would agree. If we look at AVL as well, there's some T wave inversion, and arguably if we draw a line from the line afterwards to the line before, there's a bit of ST depression, which is probably reciprocal change. All right, so this is a STEMI. This is the one you don't want to miss, and almost everybody got it. So congratulations. I think we need to get onto the questions. Actually, do we have Daniel? Do we have to finish in 5 minutes? Is that right?
Yeah, we've got another presentation at 15:15.
Right. So there was another one, but I'll maybe let you do this in your own free time. So some final top tips: focus on the process rather than the diagnosis. There are so many diagnoses that could be. I still look at ECGs quite frequently and think I have no idea. But in real life, there's always a friendly consultant cardiologist to ask. In OSCE, process, 9 out of 10 marks. If you get the diagnosis, great. Okay, have we done it? hopefully you have a simple way to interpret ECGs. And we've looked at a couple common and dangerous ECGs. There's another one there that you can have a look at. And I put on some really good revision resources as well. My top tip for all my students is go to MEU. Every single patient will have an ECG. Start at the top, go to the bottom, do your process with every single one, and you'll have done 24 ECGs in an hour. And that's it. Ask me anything except Brugada syndrome. I don't understand it. Please don't ask me about it. Hopefully that was helpful.